everyone, sir. Good evening, Professor, Assistant Professor, and my colleagues. So my talk is on non-union fracture neck of femur and its management. So my talk is based on introduction, basic anatomy and definition of non-union, causes, classification, clinical features, investigations and treatment. Coming to the introduction, basically hip fractures are common and comprise 20% of orthopedic trauma. Here the intracapsular, it may be an intracapsular or extracapsular. Intracapsular comprise of 50% of all hip fractures, and women usually outnumber the men. And the undisplaced fracture contributes 15%. So out of displaced femoral neck fractures, the fracture which goes for non-union is 20 to 30%. And most frequently, elderly female patients are prone to get fracture neck of femur. And it is more common in white females than compared to black races. For that, why it is common in white females, I'll tell you later. So some basic surgical anatomy before going to the non-union. First, I'm moving on to the femoral neck shaft angle, anteversion, hip axis length. These are the landmarks. These are some ideal landmarks you should know. Calcar femoral, blood supply, periosteum and ligaments and muscles around the hip. The femoral neck shaft angle, here the line drawn, midline drawn along the axis of the neck and another line drawn on the axis of the mid diaphysis. So where it intersects is the neck shaft angle. Normally it's around 130 to 135. If it is less, we call it as coxa vara, that is less than 120 degree. And if it is more, we call it as 135 degree coxa valga. So anteversion. Here the anteversion is nothing but is the angle subtended, that is between the femoral neck, that is axis of the femoral neck, to that of transcandular axis of the femur. The normal anteversion is 15 to 25 degree. The most important one is hip axis length. Hip axis length is nothing but the distance from the lateral aspect of the trochanteric region. Here, lateral aspect of the trochanteric region along the axis of the femoral neck and touches the inner table of the pelvis. So, an increase in hip axis length as well as the wider femoral neck and lower neck shaft angle, which is associated with increased risk of femoral neck fractures. And such long hip axis length is more common in white females. That's why white females are more prone for femoral neck fractures when compared to black races. So long hip axis lead on to greater lever arm and greater force, lower neck shaft angle leading on to fracture neck of femur. Then calcar femoral. Calcar femoral is the dense vertical plate of bone. You can see the bone. This is the posterior aspect and this is the anterior aspect. So in the posterior aspect is a vertical plate of bone, extends from the posteromedial. This is the lesser trochanter. From the posteromedial portion under the lesser trochanter radiates to the greater trochanter, reinforcing the postero-inferior aspect of the portion of the femoral neck. So this is very useful, and this has to be addressed before planning for arthroplasty. And coming on to the ossification centers, because before going to the blood supply, some points about the ossification centers. There are two ossification centers. You already know that primary ossification centers is and 4 secondary ossification centers. Primary ossification centers help for the diaphyseal growth and the epiphyseal growths and metaphyseal growths from the secondary ossification centers. So at birth, only the primary chondrogenic femoral epiphysis exists. This, my cursor shows the primary femoral chondroepiphysis. That is the only thing exists. So no other secondary ossification center appears at birth. Then it grows fastly, thereby it forms an elongated femoral neck. It forms an elongated femoral neck. By the end of one year, the most of the neck will be formed. Then forms the capitofemoral epiphysis, that is head. It appears by 4 months in case of girls and 5 to 6 months in case of boys. Then follows the greater trochanter epiphysis, that is ossification centers of the greater trochanter. So that comes by 4 years. So later on, you see the proximal femoral epiphysis is responsible for the metaphyseal growth in the femoral neck. So the proximal femoral epiphysis, this is the anterior aspect, proximal femoral epiphysis responsible for the metaphyseal growth of the femoral neck, where the trochanteric apophysis contributes to the greater trochanter, that is appositional growth, and less to the metaphyseal portion of the femoral neck, part of the femoral neck metaphysis. And fusion of both proximal femoral and trochanteric epiphysis, this proximal femoral and trochanteric epiphysis occurs by 14 in girls and 16 in boys. One important point is the confluence, the junction of greater trochanteric physis with the capitofemoral epiphysis and along the superior femoral neck and along the course of and vascularity at the junction of these three confluence, that is junction point, capitofemoral, superior portion of the femoral neck and greater trochanter. That is the vulnerable portion, and because of the proximity of the vessels, which makes the hip vulnerable to growth derangement if there is disturbance in that area. At birth, the main blood supply is the lateral epiphyseal and the metaphyseal vessels. And from 4 months to 4 years, the lateral epiphyseal vessels predominate over the metaphyseal vessels. Here the cartilaginous plate acts like a barrier. So this is the picture. This is at birth. You see the metaphyseal blood supply, and this is the epiphyseal blood supply comes from here. Here the metaphyseal blood supply. Both supplies the femoral head. There is no barrier at birth. Then later, from 4 months onwards, barrier starts. There is cartilaginous plate. That is barrier starts, and there is no crossover of metaphyseal vessel supplying the capitofemoral epiphysis. Only the epiphyseal vessels, that is on the lateral supralateral aspect, supplies the femoral head, and in anastomosis with the metaphyseal vessels outside the bone, some part of the femoral head is supplied. Then from 4 years to 7 years, what happens? Still the epiphyseal plate, that is the third picture left. Still the epiphyseal plate is present, and here the metaphyseal vessels present but doesn't cross, and lateral epiphyseal vessels, which mainly supplies the area of the femoral head. That's why it's 4 to 8 years is the crucial time. Then follows that after 7 years, what happened? Once again, the metaphyseal vessels crowd and it's hypervascular. Then epiphyseal vessels form over that area. Here, the ligamentum teres, the foveal vessels from this area starts appearing, and it contributes 8%. Later in adult, it contributes from 8 to it increases to 20%. That is, artery to the ligamentum teres supplies the remaining part of the head. So from 4 to 7 years, Ogden stated that lateral epiphyseal vessels has got 2 branches. One is posto-superior and posto-inferior. Both branches comes from the medial circumflex femoral artery. Ideally there are 4 feeders of the which supplies the femoral head. One is from the extracapsular arterial ring by Krog, capsular vessels. Another one is intramedullary ascending retinacular vessels. Then third is intracapsular subsynovial arterial ring by chunk. The last one is ligamentum teres vessels. So lateral femoral circumflex artery, where it arises from the lateral side of the proximal femoral artery. It passes between the divisions of femoral nerve and behind the sartorius and rectus femoris and divides into ascending, transverse and descending branch. You see here, this is the femoral artery, then this is the profunda femoris. From that lateral portion, not medial, but lateral portion and lateral and anterior, here the three branches: ascending branch, transverse branch and descending branch. Here the ascending branch, which goes higher, and it make anastomosis with the superior gluteal artery and deep circumflex artery. Then transverse branch, which winds around the posterior aspect of the neck, and it makes anastomosis with the inferior gluteal artery and middle circumflex artery. Then descending branch, here it goes downwards, adjacent to the vastus lateralis, and it communicates with the superior lateral genicular artery. Here apart from the three branches, that is among the three branches, the mainly that transverse branch as well as the ascending branch, which makes anastomosis with the extracapsular vessels. Anastomosis is, it contributes some amount to the extracapsular anastomosis. Then medial circumflex femoral artery, it is the main artery of the femoral head. So it passes between the psoas major and the pectineus muscle, and then it passes between the adductor brevis and the obturator externus. Then it gives off three branches. First is gives off the constant acetabular branch. Then it winds on the back of the thigh. At the upper border of the adductor magnus, it divides into ascending and transverse branch. Here the ascending branch ascends in the gluteal region to anastomose with the inferior gluteal artery, and transverse branch, it passes transversely to participate in the cruciate anastomosis. Among these, ascending branch mainly contributes the most of the blood supply to the femoral head comes from the ascending branch. This is the transaction of the blood supply at the extracapsular level. You see here, this is the femoral artery and this is the medial circumflex artery and lateral circumflex artery. So the medial circumflex arises either from the femoral artery or profunda femoris. It doesn't matter, because mostly from the profunda femoris, sometimes it comes from the femoral artery. And the medial circumflex femoral artery, as I have already told, it passes between the iliopsoas and the pectineus. Then it supplies arterial branches to the obturator externus. So it goes posteriorly. Medial circumflex goes posteriorly, while the lateral circumflex goes anteriorly. Anterior aspect of the neck is covered by the lateral circumflex, and posterior aspect is covered by the medial circumflex. So while going to the under the superior gemellus obturator externus, it gives off arterial branches. So that area is the vulnerable spot to injury to the branches of the medial circumflex femoral artery. Then it gives off medial ascending cervical branches, or medial, you call it as medial retinacular arteries. Then comes the arterial branches to the superior gluteal artery, then winds round, and lastly it ends as a lateral ascending cervical artery. So this is the larger contributor, that is larger volume of blood supply to the femoral head from the lateral ascending cervical artery. So well, coming to the other end, that is lateral circumflex femoral artery, which comes from the lateral portion of the proximal femoral artery. It gives rise to anterior ascending cervical artery. So you see, from the medial circumflex artery gives off medial ascending cervical artery, posterior ascending cervical artery, and lateral ascending cervical artery. But Anterior ascending cervical artery, that is retinacula artery, that only artery comes from the lateral circumflex artery. And so this artery, so this ring may be joined by an inconstant branch, thereby this ring, that is extracapsular ring, may be a complete ring or incomplete ring, depends upon the presence of inconstant branch. Here the picture shows the lateral cervical ascending artery, which gives off posterior-superior branch, that is from the lateral cervical ascending artery, posterior-superior branch as well as posterior-inferior branch, which supplies majority of the major part of the head, femoral head. Then from the retinacular arteries, there forms the subsynovial ring. You see the subsynovial ring. First one I have told about the extracapsular ring. This one is subsynovial ring. So retinacular arteries, metaphyseal and epiphyseal arteries, which forms the subsynovial ring. From the subsynovial ring arises the epiphyseal arteries. It's told by Truta, he said there are two groups. One is lateral epiphyseal, another one is inferior metaphyseal artery. This is the lateral epiphyseal artery and downwards is the inferior metaphyseal artery. So lateral epiphyseal artery is further divides into posterior superior as well as posterior inferior branch. The most important lateral epiphyseal artery group because it supplies the weight bearing portion of the femoral head, weight bearing upper lateral portion of the femoral head. Then extracapsular arterial ring of Krog. So it comes from the contributed by the ascending branch of left femoral circumflex and ascending branch of medial femoral circumflex artery posteriorly. So both arises from the, already I told, it comes from the profunda femoris or femoral artery or both. So from the profunda femoris, it contributes 79% and from the femoral artery 20 and both from 1%. So the intramedullary ascending retinacular vessels, once again, I will tell you that it comprises of 4 retinacular vessels. Already I have told anterior ascending, medial ascending, posterior ascending, lateral ascending. Among this, anterior, that is medial, posterior, and lateral ascending comes from the, these three comes from the medial circumflex. And anterior ascending retinacular vessel comes from the lateral circumflex. Then intracapsular, few points in the subsynovial arterial ring formed by the chunk. Here the that is the main blood supply comes from the subsynovial ring, that is intracapsular subsynovial ring. Here branches from the subsynovial ring, pierces the head just before, that is just before that, not inside the head, just 2 to 4 mm proximal to the articular surface, mainly on the posterior-superior aspect. So that is the vulnerable zone. So any fracture occurs at this area, that is this posterior-superior aspect, subcapital region, it goes for 100% necrosis. So that is in the femoral neck fractures, there may be subcapital, transcervical and base cervical. Suppose if the fracture occurs at the subcapital, that is along the posterior-superior aspect, the vessel get damaged. So it goes for 100% AVN. So Claffey has also shown that risk of AVN greatly increase if that vessel get injured. That is lateral vessel. Always think of lateral. That is lateral is very important for the blood supply. And one more thing is retinacular of weight branch. It's nothing but a bridge between the basilar artery and the nutrient artery of the femoral head. So if that retinacular of weight branch is damaged, then 100% AVN. Ligament teres. So I have told initially 8% contribute to the femoral head, and later on in the adult period, it increased to 20%. So this is so at last you can see the femoral artery give rise to profunda femoris. So 2 branches, medial femoral circumflex and lateral femoral circumflex, both forms the extracapsular arterial ring. Then there arises the retinacular artery, metaphyseal artery, epiphyseal artery, then which forms the subsynovial intracapsular arterial ring. There 2 vessels, that is lateral epiphyseal vessel, inferior metaphyseal vessel, and it get anastomosis with the artery of ligamentum teres, that is which comes from the obturator artery. So, Gautier et al. Describe there is 5 constant branches of medial femoral circumflex artery, that is superficial, ascending, acetabular, ascending and deep. Dewar estimated that contribution of medial circumflex femoral artery to the femoral head is around 82% when compared to LFCA, that is lateral femoral circumflex, 18%. When it comes to the nerve supply, here the sensory supply, mainly anteromedial portion of the joint is supplied by the obturator nerve, and anterior capsule is supplied by the femoral nerve, post aspect of the joint by the sciatic nerve, and posterolateral capsule supplied by the superior gluteal nerve. So when you try for femoral nerve blockade, it only arrests the anterior capsular pain, but most of the pain comes from the posterolateral capsule. So if you arrest this nerve, then only it leads to major part of the pain relief. That is almost not a complete pain relief, some amount of pain relief. Better, patient feels better. On the periosteum, here the periosteum has got 2 layers. One is outer fibrous layer and inner cellular layer. Because in the femoral neck, in the periosteum, cambium layer is absent. So cambium layer is nothing but the inner vascular, that is more cellular vascular area, that is absent in femoral neck, but it is present in other bones, because it is the region, it is the layer which contributes to the formation of osteoblast, thereby this osteogenesis. It's helpful in osteogenesis. And ligamentous, coming about the ligamentous support, here the capsule, mainly the capsule, hip joint capsule, mostly the hip joint capsule, anteriorly it extends from the ilium, it extends up to the intertrochanteric line. So intertrochanteric line, this is the anterior aspect. So it ends in the intertrochanteric line. Posteriorly, what about posterior aspect? Posterior aspect, it ends just before the intertrochanteric crest. That is only the lateral office uncovered. So the medial office covered. So this capsule is strengthened by the ligaments, anteriorly by the iliofemoral ligament as well as the pubofemoral ligament, and posteriorly by the ischiofemoral ligament. So here the iliofemoral ligament originates from the iliac spine. It is represented as an inverted Y, and it limits the hyperextension and external rotation of the hip. Here the pubofemoral also controls the external rotation and extension along with the iliofemoral. So iliofemoral and pubofemoral helpful in preventing the external rotation in extension as well as in flexion. But ischiofemoral controls the internal rotation in flexion and extension. So why it's important now? In case of fracture neck, how it occurs? Fracture neck, if there is a tension build up while a tension build up in the iliofemoral ligament, it leads to hyperextension of the hip and external rotation violence along with the external rotation. Thereby, it causes posterior neck comminution. So first thing occurs is the tension in the iliofemoral ligament, and that leads on to relaxation of the hyperextension as well as external rotation, leads on to fracture of the femoral neck with posterior comminution. So any disturbance in the iliofemoral ligament ultimately leads to femoral neck fractures. Then trabecular pattern based on osteoporosis. Here there are to assess the intensity of the osteoporosis based on the disappearance of the trabeculae. So if all the trabeculae is present, then it's not an osteoporotic bone. if only primary compressive trabeculae is present, then it is at the last stage of osteoporosis. The compressive trabeculae, there are 5 trabeculae. Here the compressive trabeculae always starts from the medial aspect, that is concave portion, primary compressive, secondary compressive. Tensile portion comes from the convex side, from the lateral aspect, primary tensile, secondary tensile, and greater trochanteric. So these 5 groups. So before going to the non-union neck, just what is non-union as a whole? What is non-union? According to the US FDA, non-union is defined as an established when a minimum of 9 months has elapsed since injury and fracture shows no visible progressive signs of healing for 3 months. So this is the standard definition for non-union. Initially it was there, but this definition fails to include many fractures that have no chance of proceeding union. Now comes the later acceptable definition for non-union based on Bringer version. The fracture that, in the opinion of treating physician, has no possibility of no possibility of healing without further intervention. So without further, that is without intervention, it does not heal means it is called non-union. So generally speaking, the diagnosis of non-union should not be made until clinical, not only the radiological aspect, clinical or radiographic evidence is noted that the healing has stopped, the union is highly unlikely. And the time frame for non-union differs by the location where it occurs and the intensity of the soft tissue injury. Non-union, basically non-union neck of femur is, you can define non-union in the fracture neck of femur once it has crossed the period of 3 months, whether with fixation or without fixation, whether it's united or not united. If it is ununited, still after 3 months, then you call it as non-union. But in the long bones, non-union, not so like femoral neck. So latest version is Castillo-Anderson type 3B open tibial fractures that has received appropriate surgical treatment may not be considered as non-union after this same 3-month time frame. So 3 months time frame is given only for the femoral neck, and for other long bones, more than 3 months or up to 9 months. So general causes, just I am rushing over that general causes. We already know that local causes is excessive soft tissue stripping, bone loss, vascular injury, radiation, infection. Systemic, age, chronic disease, diabetes, anemia, metabolic and endocrine abnormalities, medications. And mechanical etiologies due to the malreduction or malposition of the fracture fragments or inappropriate stabilization leads to the insufficient fixation or too rigid fixation or inappropriate implant choice. These are the mechanical etiologies for the non-union. So coming to the non-union neck of femur, why it is common in neck, non-union common in the neck? Because of the following reasons. One is absence of cambium layer. Already I told that periosteum has got 2 layers, outer fibers, inner cambium. So lack of that osteogenic vascular cambium layer leads to decrease in the healing potential. Then continuous synovial bathing. So and avascularity, as the healing callus comes only from the femoral shaft because there is no callus formation at the fracture site because of the absence of cambium layer. And direct tamponade effect, poor bone quality due to osteoporosis, that is one of the cause for non-union. And chondrogenic factors in the synovial that inhibits the callus formation, that is lack of more of anti-angiogenic factors in the synovium leads to that is it avoids callus formation. Then high fracture angle, that is Powell's type 3, more vertical fracture, it is one of the cause for non-union. So what are the factors contributes to the non-union? Already told, that's loss of fixation, inaccurate reduction, vascular insufficiency, posterior comminution, and if you neglect the treatment for non-union, that is neglect the fracture for fracture neck of femur, treating conservatively. There are two classifications based on radiology. We classify non-union, Sandhu et al. Another one is lightened classification. Here, the Sandhu described a classification system where for the femoral neck fractures. We classify into 3 stages. Stage 1. Here, the parameters you have to take is fracture surface and the size of the proximal fragment and the gap between the fragments and the head of the femur. Any shows signs of avian or not. So these are the 4 parameters you should take. So if the stage 1 is fracture surface are irregular, still irregular, and size of the proximal fragment is adequate, that is 2.5 centimeter or more, but gap is less than 1 centimeter, and the head of the femur shows no signs of avian. Stage 2. Here the fracture surface are smooth, not irregular, smooth and sclerosed. Here the proximal fragment still remains 2.5 centimeter or more, but the gap is increased. Instead of 1 centimeter, it increased to 1 to 2.5 centimeter. But still the head is viable. Head of the femur is viable. Then stage 3, that is fracture surface are smoothened out. The size of the proximal fragment is less than 2.5 and gap is more than 2.5. There is wider gap. And head of the femur shows signs of non-viability. Then other classification is Lighten's classification. Here it tells that type 1 is inadequate fixation or non-anatomical reduction. Type 2 is loss of fixation with fracture displacement. And type 3 is fibrous non-union with no displacement based on the fixation. With no displacement and intact fixation. So what are the clinical features? What do you see in fractured neck of femur? So here the affected lower limb appears shortened, and there may be, if it is a old fracture, there may be wasting of thigh as well as the calf muscles. No exaggerated lumbar lordosis, and both anterior superior spine are at same level. No scars or sinuses. That is, may or may not be present. And on palpation, you have to find out any warmth is there. Sometimes infective etiology is also one of the cause for non-union. So you have to, as a routine, you see the warmth. Then corpus triangle tenderness, if it is painful non-union or non-painful non-union. Then important one is femoral pulse. You have to feel the femoral pulse, whether it's equally felt or not. Most of the time, if it is equally felt. So in an unstable hip, if you feel the femoral pulse, mostly it may be a non-union neck. If you don't feel the femoral pulse in an unstable hip, then it may be a dislocated hip. Only if the head is remain in the place, then only you can feel the femoral pulse. And you have to see the GT, whether it's regular or elevated. That is how far shortening of the limb is assessed by the elevation of the GT. Movements, all the hip movements is exaggerated. So by definition, non-union is nothing but painless, abnormal, mobile, the abnormal movements, exaggerated movements in any two planes is called clinically, we call it as non-union. So here it is there exaggerated movements in all planes, and here you have to measure the apparent as well as true shortening. So both confines to the supratrochanteric region, which is confirmed the Bryan's triangle. Telescopy is positive in non-union neck of femur, and Trendelenburg is also positive. So Bryan's triangle, you know the Bryan's triangle, the line drawn from from the greater trochanter, greater trochanter to the ASAs, another line perpendicular, that is a horizontal line, then another line, perpendicular line cutting the both lines. So this is the base. The base is shortened, then it's supratrochanteric shortening. Nelaton's line. Nelaton's line is the line joining the ischial tuberosity to the anterior superior leg spine. This is done in the patient in lateral position. So affected hip is in the top. So if you draw a line, if the GT lies, touches or below, then there's no deformity. If it goes up, then it is a supratrochanteric shortening is present. Shoemaker's line in supine position. This is taken in supine position. You have to extend the line connecting the GT, that is greater trochanter, to the anterior superior spine. If it crosses above, there is no shortening. If it goes below the umbilicus, then there is a supratrochanteric shortening. That is the proximal portion of the shaft femur has gone up. Then Chinese line. Here the line joining the two anterior superior leg spine as well as the two GT. So it is parallel. If there is no supratrochanteric shortening, it is disturbed or converged. In case of affected side, it gets converged. And another method is block method. There is Coleman block method to assess the shortening. That is how far shortening is there, 5 cm, 10 cm, based on that. You have to match the tiles so that the patient may not tilt this side or that side, stand straight. So what are the causes for supratrochanteric shortening? One is main important causes, non-union neck of femur. Another one is posterior dislocation hip, then congenital dislocation, that is developmental dysplasia hip, then coxa vara, class Perthes, and some amount of SUFI. Telescopy. Telescopy is very important clinical test to say it's an unstable hip. Here, you have to flex the hip to 90 degree and one hand with the thumb on the anterior superior spine and remaining fingers over the soft tissue, that is over the greater trochanter. So you do push and pull. If you feel the GT, it means it's an unstable hip. That is, if you pull it, if you don't see the GT, then it's then both correlates. It's an unstable hip. That is, it may be a case of non-union fracture neck of femur or femoral head fracture, whatever it may be. Lever arm defect. So posterior telescopy occurs in non-union neck of femur, old unreduced posterior dislocation hip, and paralytic hip, that is abductor weakness. So Trendelenburg test. So in the Trendelenburg, mainly the aim of the Trendelenburg test to assess the strength, that is abductor mechanism, whether it's intact or not. Here there are three components. One is the fulcrum. The fulcrum component is formed by the head of the femur. So this is the joint, acetabular cavity. This is head. So this is head is formed by the fulcrum is head of the femur. Then lever arm. Lever arm is by the head, neck, and the trochanter. Then power arm is the abductors, that is gluteus medius minimus. That is the abductors. If there is any defect in the any three components, then Trendelenburg test is positive. So normally, if you ask the patients to stand on the normal hip side, there is an unaffected hip, unaffected leg, the pelvis is raised on the opposite side, that is affected side pelvis is raised. Suppose in case of if the weight bearing, if you ask the patient to stand on the affected side, then the sound side will sag. So if the sound side sags, then you call it as Trendelenburg test is positive. Then fulcrum and any disturbance, that is if the fulcrum is defect, in case of posterior dislocation of hip, fulcrum defect, and power arm defect like poliomyelitis or myopathies leading on to weakness of the gluteus medius leads to power arm defect that may cause positive Trendelenburg test. Another one is lever arm defect, any fracture at the femoral neck, head or trochanter leading on to coxa vara, that also leads to positive Trendelenburg test. So you have to assess the three components. Where is the defect? Then moving on to investigation, As a routine, you know that X-ray pelvis with both its AP as well as cross table lateral view you have to take. And also one more view is, important view is both X-ray pelvis mainly to assess the portion of the femoral neck, how far it's present, whether it's resolved or not. So in the AP view, you can see if you draw an imaginary line, if this imaginary line from the superior aspect here passing on to the medial aspect of the head, femoral head and shaft, if it forms a curve, Shenton's line, it's unbroken, it's a normal hip. Here it is broken. Then there is some disturbance in the femoral neck shaft. Either it may be a fractured neck or dislocated, whatever it may be. Here it's a fractured neck of femur. So in lateral view, you find some disturbance. If you draw a line, instead of straight line, there is a break here. And also you can assess by the Lowell's S-shaped curve. There's a break in the Lowell's S-shaped curve in the lateral view. Then there is a fracture neck of femur. And this is the unreduced hip. This is the importance of traction and rotation view. By this view, you can assess the availability of the proximal fragment. How far the length of the proximal fragment from fovea to the base. So based on that, we can treat the patient accordingly. One more importance of lateral view. So there is a angle called posterior tilt angle. Is the angle measured between the mid column line passing through the femoral neck, one line. Another line is a radium column line, which is the proximal portion of the femoral neck and head. So, and if you extend the mid column and radial column line, there is an angle called alpha angle around the caput circle. If this angle is increased, then whatever may be the fixation, the femoral neck fracture goes for, if it is goes for non-union, that is chance of non-union is more. Coming to bone scan, here the depends upon the uptake. If it is reduced uptake, it's a non-union. Well uptake, it's a healed fracture. Nil uptake, avascular necrosis. And CT scan is the best one to assess the fracture union. After fixation, to assess the fracture union, CT scan is the best one. It is useful to see. Also, it is useful to assess the posterior comminution, amount of neck resorption, microfractures, subchondral collapse, that is segmental collapse, can be assessed. MRI is for two indication. It is useful to assess the viability of the femoral head, whether the femoral head is viable or not. Another one is undisplaced fracture in early condition, that is early stages, that is undisplaced fracture or stress fracture. You can see a fluid level in the transverse axial cuts. You can see a fluid level in the coronal cuts. You can well see the fracture. So this is the area of fracture. So treatment basically depends upon the age and the physical status and duration of the non-union, viability and sphericity. That is whether the femoral head is maintained or it's there any segmental collapse, and amount of resorption of the femoral head, any limb discrepancy is there or not. So treatment wise, you broadly categorize into two age groups. That is younger age group, which falls less than 60 years, and older age group more than 60 years. Less than 60 years, you go for preservation surgery, head preservation surgery, and more than 60 years, you go for head sacrificing surgery. So in the head preservation surgery, these are the options. One is you can do fixation alone, or osteotomy with fixation, which is an indirect method, does without opening the fracture, or muscle pedicle bone graft, opening the fracture and putting a graft over that along with muscle pedicle graft directly over the fracture site along with the fixation. And another one is vascularized or non-vascularized stud graft, fibula stud graft, or combination of all, osteotomy bone graft. What is the aim behind treating the non-union? Mainly to improve the biomechanics. In case of viable head, if the femoral head is viable, you have to improve the biomechanics. Hello? Hello?
Prabha, sollu Prabha.
Sir, is there any problem, sir? Onalla, sir.
Onnilla.
Okay, sir. Thank you. Then another one is to improve the vascularity and bone stock in case of non-viable femoral head. So if the femoral head is viable, you just alter the biomechanics. That is, you have to improve the biomechanics. If you improve the biomechanics by osteotomy, definitely the fracture will unite. Another one is in non-viable head. The main problem is viability, that is vascularity. You have to improve the vascularity either by vascularized bone graft or muscle pedicle bone graft. So fixation alone is tried if the fracture occurs. It can be tried within 3 weeks of injury, which are undisplaced or reducible fractures. Then osteotomy is an option. It's a surgical procedure used to obtain a correct biomechanical of the extremity so as to achieve a equivocal load transmission. Then you have to maintain the mechanical axis. Perform with or without removal of portion of the bone. So main principle is useful in viable femoral head, increases the contact area, restores the biomechanical advantage, moves the normal articular cartilage into the weight bearing zone, improves the coverage of the femoral head. And in non-union, thereby shifting the weight bearing axis, you can achieve non-union. You can achieve union by converting the vertical forces, shearing forces into horizontal forces, compressive forces. So ideally, you can typify the osteotomy into displacement osteotomy or angulation osteotomy. In displacement osteotomy, here the longitudinal axis of the distal fragment, longitudinal axis of the distal fragment. This is the distal fragment. This is the proximal fragment. Just assume. So the longitudinal axis of the distal fragment remains parallel. It has to remain parallel to the longitudinal axis of the proximal fragment. So this has to be parallel to this one. The example is McMurray's displacement osteotomy, and another one is Powell's varus displacement osteotomy. Then angulation osteotomy. Here the longitudinal axis of the distal fragment forms an angle with that of proximal fragment, either in the sagittal plane, extension plane, extension osteotomy, or coronal plane, varus or valgus. Examples are Dixon osteotomy, Shan's angulation osteotomy, Blount's osteotomy, Powell's valgus intertrochanteric osteotomy. In 1922, Shan's reported his low subtrochanteric abduction osteotomy. 1935, later on, Powell's described osteotomy at the intertrochanteric level. And 1936, McMurray treated the non-union fracture neck by doing an oblique displacement osteotomy. 1955, Cherry did pelvic osteotomy for the coverage of the femoral head. And Blount and Moore did eye subtrochanteric osteotomy with blade plate fixation for the fracture non-union neck of femur. So this is the diagram showing Shan's osteotomy. It's an angulation osteotomy. These two are displacement osteotomy. The femoral, the distal portion is displaced medially. This is angulation osteotomy. This is also an angulation osteotomy. So displacement osteotomy, I think the separate session will come. Will be taken by Dr. Amarnath later, so I am not going in detail. McMurray's oblique displacement osteotomy, the main aim is to shift the longitudinal axis in align with the proximal, thereby achieving the non-union, achieving the compression of the fracture site. Then whereas here the piece of bone from the medial aspect you have to take at the lesser trochanter level, that is intertrochanteric level, then you have to displace the distal fragment medially. So here also the longitudinal fragment, distal fragment, you keep the distal fragment in align with the proximal fragment, thereby shifting the weight bearing axis medially. Here by doing that osteotomy and shifting it medially, you can achieve the normal weight bearing axis. Angulation osteotomy, same thing, instead of displacement, you have to angle. Distal fragment has to angle either valgus or varus or in extension plane. So this is Dixon. Shan's angulation is first tried in congenital dislocation of hip. Also, it's useful for non-union neck. Then coming to the muscle pedicle bone graft. So viable, that is, if the femoral head is vascularity is pory, you go for, that is doubtful, you go for muscle pedicle bone graft based on that piece of bone, that is quadratus femoris based. It may be Mayes or Judet, that is a piece of bone taken along with the quadratus, that is a portion where the quadratus femoris get inserted. A piece of bone with quadratus femoris is taken. This is the posterior aspect. This is called Mayes, and keep it over the fracture area, non-union site. So if it is done in dog, that it is called Judets. Gluteus medius based, a piece of the GT along with the gluteus medius, that's hips sartorius base, Lee et al. And tensor fascia lata base is Bakshi. And one, instead of taking a bone, piece of bone, if you take a periosteal flap, is called muscle myoperiostral grafting. Quadratus femoris base periosteal grafting. This is the Mayes muscle pedicle graft. Here the T-shaped incision. This is done through posterior approach. T-shaped incision of the posterior capsule is done, mapping out the quadratus femoris graft along with the piece of bone is taken. Then the insertion point is taken. A trough is already the fracture non-union site. You want to open the non-union site, and a trough is created. To that trough, you have to insert that graft and fix it with screw 3.5 mm cancellous screw with washer from posterior to anterior aspect. It has to be always combined with the routine cannulated cancellous screw fixation. Then Bakshi et al. Muscle pedicle graft is a tensor fascial lata with the iliac crust. Iliac piece of iliac crust is taken. It is done through anterior approach. Here the graft is placed over the anterior aspect of the anterior aspect of the fracture. It's combined with routine cancellous cancellous screw fixation. So this is the picture depicting that. This is the approach here from that anterior approach, Smith-Peterson approach. The important one is you have to a little bit careful while doing that. You have to isolate the lateral cutaneous nerve thigh, which comes while dissecting the anterior, while going along that anterior superior leg spine. Then one is, so far I have told about the 8 preserving surgery. Then another one is 8 sacrificing procedure. So all know that is unipolar arthroplasty, that is hemiarthroplasty. It may be hemiarthroplasty, it may be unipolar or bipolar or total hip arthroplasty, and final one is girdle stone arthroplasty. And total hip replacement is the treatment of choice mainly in cooperative independent individual with normal lifespan. Hemiarthroplasty done in a patient with much less demand, leading a sedentary lifestyle. Now, how to decide which treatment? You know the treatment, that is 8 preserving surgery and 8 sacrificing surgery. So when to decide? You are in dilemma. If you see a fracture neck of femur comes within 3 months, that is, you call it as late presentas. Irrespective of the vascularity of the head, good reduction achieved, neck shaft angle maintained, and if presented within 3 weeks, fix it. If presented 3 weeks to 3 months, that is cut-off period, 3 months. After 3 months, you just say the fracture has gone for non-union. So up to 3 months, you do fixation. Fixation.
I think சோழன் மியூட் பண்ணு சோழன் அவங்கள யாரும் தெரியல.
Yes sir, mute பண்ணு sir.
So if presented 3 weeks to 3 months, we go with fixation with bone graft or muscle pedicle bone graft. After 3 months, then you end up with osteotomy with bone graft. And if there is a segmental collapse, even within 3 months, if you see it in the radiology, that is X-ray wise or CT wise, directly you go for replacement arthroplasty. And arthro is a rare option, maybe tried in younger individuals. Then age group wise, if it falls, it is more than 3 months, then it's a confirmed non-union. And the age group 20 to 40 years. Look over the neck, femoral neck. whether it's observed or not observed. If it is not observed and head is viable, then fixation alone won't work because it has crossed the 3 months. You just quantify as non-union. That is fibrous. Some fibrous tissues has gone as formed in between the fracture. So you have to fix it. Along with that, you have to augment the fixation with bone graft or osteotomy or muscle pedicle bone graft. So you have to preserve the head as far as possible. If the neck is observed and the head is not viable, then there are options. You can, younger individuals, arthrodesis, if it is an septic hip or failed fixation, girdle stone arthroplasty. If the acetabular cartilage is still intact, you can go for bipolar. That is modular bipolar. And if the articular cartilage is of poor quality, then go for total hip replacement. And it falls on middle age group, 40 to 60. The same thing, head is viable, neck is not resolved, fixation with bone graft or osteotomy if the leg is short to lengthen to equalize the limb length discrepancy. If there is a segmental collapse at any stage, there is a segmental collapse, to go with arthroplasty. If there is no segmental collapse, still there is chance to preserve the head by doing that osteotomy or muscle pedicle bone graft. So treatment based on Sandhu staging, already I told, based on the 4 parameters: fracture surfaces, whether it's a regular, smooth or smooth sclerosed or smooth surface, or proximal fragment, whether it's a 2 point, less than 2.5, more than 2.5 or less than 2.5. A fracture gap, if it is forms less than 1 centimeter or 1 to 2.5 centimeter or more than 2.5 centimeter. And signs of avian, whether it shows signs of avian, stage 1 and 2, no avian, 3 is definite avian. So stage 1 and 2, stage 1 and stage 2, the same treatment. That is, you can try with closed reduction, internal fixation with 1 screw or double fibula graft, or 2 screw with single fibula graft. Or you can try quadratus femoris, that's muscle pedicle graft. If there is a limb length discrepancy, you have to combine with abduction osteotomy. Stage 2 follows the same. Stage 3, there is some option for valgus osteotomy in younger individuals, but mostly you go with, since in stage 3 is a complete avian, that is shows signs of avian, you go with arthroplasty. So still bipolar, modular bipolar, arthroplasty. For arthritic, there is no obvious arthritic changes. If there is an arthritic changes present more than 60 years, cemented modular bipolar or THR in case of osteoporosis. And if there is a posteromedial defect in the neck, you should get prepared with the calcar augmented long stem bipolar hemi or calcar augmented long stem THR, total hip replacement. So as a whole, neglected fracture neck, femur in adults less than 60 years, you see whether it falls more than 12 weeks or less than 12 weeks. Less than 12 weeks, you preserve the head by doing the fixation of fibula stud graft or osteotomy or bone graft. If it is more than 12 weeks, go with an MRI. You take an MRI and see whether it's a head is viable or not viable. If it is viable, then you have to assess the proximal fragment, length of the proximal fragment. If the proximal fragment is more than 2.5, fracture gap is less than 1 centimeter, you still able to preserve the head by doing osteotomy with bone graft. If it is less than 2.5 and the fracture gap is more than 1 centimeter, then you straight away go with the replacement arthroplasty. And other aspect, if the head is not viable, then the same option, replacement arthroplasty. So latent classification treatment, there's latent classification is another radiological classification only based on the fixation, after post-operative fixation. So if it is an inadequate fixation, you say it as type 1 or non-anatomical reduction. If there is a loss of fixation with fracture displacement, major fracture displacement, then you call it as type 2. And if the fixation is intact, but fibrous tissue form in between the fracture site, you can say it as type 3. So in type 1, you remove the fixation and realign the femoral head or neck and use the muscle pedicle graft, because it's an inadequate. You have to do and you have to reduce the fracture accurately. Here the I have already shown. Then another one is fracture is that is fixed, but it is displaced. So loss of fixation with major displacement. So the displacement can be corrected by osteotomy. So remove the initial fixation, then revise the fixation by doing the osteotomy, thereby converting the vertical shear force. Here the vertical shearing force is converted into a compressive force by doing a valgus osteotomy. And type 3 is the fixation is good, but there is a fracture gap. There is non-union site is still there, gap is there. So you have to drill that non-union site and fix the fracture with fixed angle device. That is a DHS with re-erosion angle blade plate with bone graft. So at last, the treatment based on Campbell, what they say now, fracture neck, if it is less than 60 years or more than 60 years. More than 60 years, whether it's viable or not, we go with arthroplasty. And 60 to 75 years, we go with total hip replacement. Among the people, 60 to 75 years, THR is useful. After 75 years, we go with hemiarthroplasty. Less than 60 years, the same thing. Head is viable or not viable. Head is viable. You still try to preserve the head by doing osteotomy. If head is not viable, less than 21 years, you go with, in younger individual, arthrodesis, but rarely prosthesis in less than 21 to 60 years, and THR is the treatment of choice. Arthrodesis is not nowadays trying. In olden days, they are trying. So my take-home message is always treat the medical cause as well as risk factors for non-union. In case of confirmed non-union, the femoral head is viable. Always do the procedure, whether it's osteotomy or muscle pedicle graft, right, or abduction osteotomy, to preserve the femoral head. If the femoral head is not viable, you do the procedure to replace the femoral head. So our ultimate goal is to provide a well stable, painless, mobile head.
You covered completely. I think as a postgraduate, they have to know all these, except for a few points that I want to say. One is, is 20 to 40 years and 40 to 60 years. You mentioned about bipolar hemiarthroplasty and hemiarthroplasty, right? If the cartilage is intact.
Yes, sir. Instead of going for if the article cartilage is viable.
No. So for exam sake, okay, exam sake, at less than 60 years, if you want to do a replacement procedure, always total hip replacement. Okay. No question of hemiarthroplasty or bipolar, even bipolar arthroplasty can't be done in exam. Now, on an exam point of view, you have to say total hip replacement only. Even 60 to 75 years, Campbell says total hip replacement. Out to 20 to 40 years, how you can accept hemiarthroplasty? So replacement procedure, if the head is not viable, then you are going to go do a replacement procedure. The total hip replacement will be a very safe answer for the postgraduates in exam. Bipolar panel, modular bipolar, then you can convert into THR, all this stuff you can say. But on an exam point of view, I will advise to say total hip replacement. Okay, even up to 75 years, you can say total hip replacement very, very safely. More than 75 years non-union, then you can think of hemiarthroplasty or bipolar arthroplasty. Even 60 to 75 also you can accept bipolar modular arthroplasty can be accepted, but less than 60 years I don't think bipolar you can say in exam. Better to say as total hip replacement. Other than that, there is no issues at all. I think this. Hello.
Good evening, sir. Sir, actually, is there any indication specific for unipolar versus bipolar, sir, in hemiarthroplasty?
In hemiarthroplasty, unipolar or bipolar?
Yes, sir. Is there any special indication in particular cases unipolar is best, or in particular cases bipolar is best? Like that, is there any, sir, or else both are same, sir?
See, so many studies have said that after a period of time, all the bipolar will function as unipolar only. Okay, there are so many studies. Bipolar podum it functions as unipolar. But what they say is bipolar is modular bipolar. Okay, what this book says is modular bipolar. Modular bipolar is after a point of time when the cartilage gets damaged, you take out the outer head. Okay, the inner head will be some 22 size or whatever it may be. That will fit into another, into the acetabulum or cup. So bipolar in the sense, nama solra bipolar kadayadu. Okay, va?
Okay, sir.
Don't think about this fixed bipolars. I'm telling about modular bipolar. There are two bipolars, fixed bipolar and modular bipolar. Now almost fixed bipolar is going out of existence, and they're all doing only modular bipolar. So if you want to convert into total hip replacement, you always have a possibility to convert into THR.
So is there any role of
but there is no specific indication. No.
Is there any role of modular bipolar in young patients, sir? In young patients?
No. Exam no. Don't say that in exam. No. Nobody will prefer.
Okay.
60 years, less than 60 years, don't say bipolar.
Okay, sir. THR.
Less than 60 years, don't say. Okay, yeah. Less than 60 years, above 60 years, you can say. 60 to 75, above 75, you can say. Examiner always. Some examiners will accept modular bipolar. Definitely, they will accept. Okay. கொஞ்சம் மாடர்னா இருக்க எக்ஸாம்னஸ் அக்செப்ட் பண்ணுவாங்க. பட் பாருங்க டிஹெச்ஆர்னு சொல்லுங்க, ஒன்லி டிஹெச்ஆரா வேற எதுவும் பண்ண மாட்டீங்கன்னா அப்ப நீ ஹேவ் டு கிவ் தட் ஆன்சர். So you have to assess the examiner's pulse and then do. Prabha, you want to say something?
Sir, suppose the patient is a high laborer and wants to squat, cross leg sit, then which replacement you want to go? Suppose the examiner asks for that. In such scenario,
any replacement you cannot allow squatting.
Excisional arthroplasty, sir.
No, sir. Bipolar, sir.
Enama kekla. Hello.
In bipolar, you can able to squat, cross leg sit, sir, when compared to total hip replacement.
No, but even then you cannot allow. Even if you do a bipolar arthroplasty, you cannot allow the patient to sit cross leg. No. That you cannot allow. So bipolar is not an answer for cross leg sitting. That is not the answer for cross leg sitting. That is not possible.
Squatting, okay, sir.
Any other question, ma? Because this is a mukkiyamaana or topic, so definitely we expect a lot of questions. The presentation was so nice. Yeah.
Sir, hello.
Venkatesh Kele. Venkatesh.
Sir, Prabhakar sir mentioned about fracture non-union, intracapsular and extracapsular. Is there any tests to differentiate between intracapsular and extracapsular by clinically, sir?
Prabha, Venkatesh, nee answer solla. What do you think? What is the answer? There is an answer, definitely. For intracapsular and extracapsular, non-union is very rare. Extracapsular is very rare. But what do you think? Enna finding irukum clinically? Prabhakar answer solluvar unakku. Pain la irukadu. Non-union appo enga pain irukku?
Extracapsular more of external rotation, sir.
More of external rotation. And one more important thing, see, when there is a trochanteric fracture, the trochanteric area will be thickened. It will be widened, it will be broadened, it will be irregular. All these things you can see in palpation. Okay? Whereas in fracture of neck of femur, the trochanter will be normal.
Yes.
So there will be thickening there, there will be widening there, some irregularity will be there. Okay? So the trochanteric prominence will be a little posterior. So more posterior than, as somebody said, more external rotation. It will be more posterior.
Yes, sir. Okay. More posterior, shortening and thickened trochanters.
Yes.
Collapse means what does it mean, sir?
What? Hello?
Segmental collapse means what, sir? Segmental collapse.
Segmental collapse. That's why it's a suppose the femoral head, if it is cross the stage 2, stage 2B, that is the segmental collapse. Crescent sign.
It is something like crescent sign.
Crescent sign.
Segmental collapse na one portion of the head alone is not the entire head is collapsed. Only the weight bearing portion of the head alone will be collapsed.
Yes, sir.
So that is what I think he is mentioning. Yeah, the superolateral portion will be collapsed. And one more. Repeat your question.
So is there any role for osteotomy in younger patients, sir? And treatment options straight away, we can say THR, or the examiner asks, is there any?
I have clearly told.
I am audible.
Yeah, yes, it's audible. I have clearly told If the femoral head is viable, you still go with the osteotomy with bone graft. If the femoral head is not viable, then you go for replacement, arthroplasty. Hello.
Jagdish தானே?
Sir, yes, sir.
Jagdish தானேமா?
Yes, sir, yes, sir.
our presentation ரொம்ப clear-ஆ explain பண்ணாருமா. He explained very clearly. See, I will reframe your question. Say, Prabha, his question is, why not, if an younger patient, why not straight away go and say osteotomy? Why do you want to say, fixation? Why you want to directly say osteotomy? I think that was his question. See,
Yes, sir.
what is the disadvantage of doing an osteotomy? See,
Yes, sir.
that is his question. If you say osteotomy, why you should not say osteotomy? What may be the disadvantage of doing a primary osteotomy in an young person?
Yes, sir.
Yes, sir. Sir,
Prabha, your question is to you.
Yes, sir. Yes, sir. Yes, sir. Actually, basically, the osteotomy has been tried. Our aim is to preserve the femoral head and the coverage, to give an adequate coverage. So, if that is attained by osteotomy, then there is no need to destroy, that is sacrifice the head. If everything is attained by, if the mechanical axis is aligned and properly, you can able to displace it, and the weight bearing, that is head is viable, and you have to you can compress the fracture site, then there's no need for head sacrificing surgery. So
Okay.
His question is totally something slightly different. I think, Prabha, maybe I'm not able to explain to you what his question is. Jagdish, I'll tell you the answer. So
Okay,
what
sir.
the answer is expecting is, one is, osteotomy is a procedure where you convert the normal biomechanics. Okay. So primary, if you do osteotomy, you are going to convert the biomechanics. You're going to change the biomechanics. So future, when you do a THR, okay, suppose it fails, your osteotomy fails, and you want to convert into
Okay, sir.
total replacement later, there is a difficulty.
Okay, sir.
You might not be able to use the regular
Okay, sir.
processes sometimes. Okay. So on the time, there might be a difficulty.
Okay,
So
sir.
that you have to take an option whether you want to do a
Okay, sir.
replacement or an osteotomy. But primary, in a young patient,
sir.
osteotomy always, if the head is viable, that's what he is mentioning. If the
Oh.
head is viable, okay,
Okay.
there is no question of any AVN.
Okay, sir.
Young patient, okay, you have to tell osteotomy in exam.
Okay, sir.
If the head
Okay,
is
sir.
viable, that's what I'm telling you. Suppose
Okay,
AVN வந்துருச்சுனா கூட
Okay,
osteotomy பண்ணலாம். ஆனா எக்ஸாம்ல AVN வந்துருச்சு சார், இனிமேல் osteotomy பண்ணி பிரயோஜனம் இல்ல.
Okay, sir.
I'm changing the biomechanics, so conversion to THR will be difficult. So I'm not doing osteotomy here. But if the head is viable,
Okay, sir.
I will plan to do a totally I will plan to do an osteotomy. Then I will convert the shear forces into compressive forces.
Okay, sir.
Or I'll convert Powell's type 3 into Powell's type 1, and then allow the fracture to heal. That will be my primary aim.
Okay, sir.
அப்படின்னு சொல்லணும். சரியா?
Okay, sir.
Okay.
Okay, sir. Thank you, sir.
So any other questions?
Sir, if
இதுல நிறைய இந்த doubts நிறைய வரும்பா. These are basic doubts. Yeah.
Sir, if we converting the shearing force into compressive force, in the young age group after doing osteotomy, later if he is developing arthritis in older age, then we are planning for replacement surgery. If there is any problem for related to biomechanics, sir. Sir, if in a young age group we are doing an osteotomy, sir, so basically we are converting the biomechanics, that is shearing force into compressive force. So later the patient is attaining like 50 or 60 with arthritis after the surgery. So if we planning for a total hip replacement or a replacement surgery, so it will be any difficult for doing that replacement, or it will be normal?
Sir, that is already explained, no?
Prabha,
Sir.
இல்ல டெஃபினட்டா நாகராஜன் நீ தான கேட்ட?
சார் ஆமாங்க சார்.
நாகர்
சார்
இல்லப்பா, அதுதான் நான் சொன்னேன். இப்போ டெஃபினட்டா there will be a change இல்ல. Adada, see, that is why people don't do a medial displacement osteotomy now. Complete alter ஆயிடும். Then it's very difficult to do a THR. McMurray's osteotomy nowadays not that much done. Valgus osteotomy தான் பண்றோம். Okay. valgus நீ valgize பண்ணிடுறல்ல, அந்த proximal fragment valgize பண்ணிடுறல்ல, so your normal processes will not go inside. Your processes will not go inside. So that time you have to go in for some special type of processes which might be very costly. Pannalam. Okay? Pannalam. It can be done. THR can be done with some kind of special, but like, SROM stem with a completely different, angulation. And the stems, special stems. That with that you can do a THR, but it will be very costly and technically it will be very difficult to do that. If you do a very mild, 20 to 30 degrees or 20 degrees of an osteotomy, or valgus, then you can still go with a normal process itself. But if you do a very severe, valgization more than 20 degrees, then it might be difficult to do with the normal processes. Normal use பண்றோம் corail stem அதெல்லாம் யூஸ் பண்றோம் இல்லையா, that might be difficult. It will not go inside. அது போய் ஒரு cortex ல இடிக்கும். So that is not designed for a valgus stem. புரியுதா? So there are some processes which are available which you can do. But they are costly and technically it becomes a little difficult. So that is why normally when you do an osteotomy, you make sure that this ends up the problem. But even if it doesn't end up, there is a solution. But it is difficult. Adha solra panna koodadun kediyadu. Example, it might be difficult to do a future total hip replacement.
Future, okay, sir.
Yes, it is difficult. It is difficult.
Okay, sir.
Sir, in osteotomy also, the abductor muscle, that is the power of the abductor muscle is maintained, sir. That is very useful for the future THR. Sir. If that is disturbed, definitely future THR will be difficult.
In future THR, when you do, you increase the length. Okay, then you can always maintain the abductor length. So it is not that valgization pannada and maintain avun kadiyadu. Future THR பண்ணும்போது
இல்ல சார் too much
and the center of rotation maintain பண்ணிரோம்ல.
கண்டிப்பா சார். இல்ல too much valgization
that time we can manage.
Yes sir.
Yes. Yeah, so the point is that too much of valgization will give a problem.
Yes sir.
So சொல்லுமா.
Outstanding cases of non-union sir, necropsy.
Hello sir.
சொல்லுப்பா, யார் கேக்குறீங்க? Just introduce yourself and ask the question.
வரதராஜன் sir.
வரதராஜன் சொல்லு.
Sir, sir, it is essential to take MRI for all the case, sir. Sir, am I audible, sir?
Yes.
Sir, Prabhakar, sir.
Prabha, question for you only. Only.
Actually, I told you less than 3 months, there's no need to take an MRI, provided if you see any segmental collapse. So if more than 3 months only, you can take an MRI to decide whether the femoral head is viable or not viable.
Sir, so less than 3 months, there is no need to take MRI. No need to take.
Yes.
Straight away, we can go for a fixation.
Yes, you can assess the based on Sandhu staging, you can assess the length of the proximal fragment, and there is any segmental collapse with the CT scan.
Okay, sir.
Nothing was there. You just go with osteotomy procedures. If the head is
இல்ல சார், நம்ம இப்ப 3 மந்த்க்கு முன்னாடி நம்ம கண்டிப்பா ஏவிஎன் போக முடியும், நமக்கு ஷூரா சொல்ல முடியல சார். அப்போ சோ நம்ம
if there is a segmental collapse, suppose supralateral portion, what Sarah has told, supralateral portion collapse is there.
Okay sir.
You take an MRI. Sir,
வரதராஜன், இது வந்து எக்ஸாம்ல இந்த क्वेश्चन கேட்டா ரொம்ப கேர்ஃபுல்லா ஆன்சர் பண்ணனும். ஓகே, நீ எக்ஸாம்லோட பல்ஸ் பார்க்கணும். One is MRI will give you an assessment whether this head is going for AVN or not. Okay, so that is what, whether the head is viable or not. So less than 3 months la ஒண்ணும் பெருசா தெரியாது. But தப்பு இல்ல, when you want to say MRI, it is not wrong. But you want to take an MRI அப்படினு கேட்டாங்கன்னா, yes sir. So why you want to take an MRI will be the next question. That's what I'm telling you. So why you want to take MRI?
Okay sir. Head viable னு பார்க்கிறதுக்கு.
Whether you So next question அதான் கேட்பாங்க. ஏன்னா what is the reason you want to ask? Less than 3 months தானே, viability எப்படி நீ பாப்பன்னு கேட்பாங்க. புரியுதா? சோ நீ அடுத்து யோசிக்கணும். அப்போ நெக்ஸ்ட் வந்து MRI எடுக்க மாட்டியான்னு கேட்பாங்க. MRI வேண்டாம் நீ சொல்லிட்டேன்னா, MRI வேண்டாம், are you sure that you want to take MRI அப்படின்னு கேட்பாங்க. Yes sir, less than 3 months only. In X-ray, I'm not able to see any signs of AVN. Okay, there is no sclerosis, there is no subchondral collapse, there are no lytic areas. So I'm able to see a very clear contoured round shaped head without any signs of AVN. So I might not require an MRI in this case, sir. So you have to justify your answer. That's what I'm telling you. Whether you say you want to take MRI or you don't want to take MRI, you can say both. ரெண்டுமே நீ சொல்லலாம், provided you have an answer to the next question.
ஓகே சார். இல்ல சார், நம்மளோட பிராக்டிகல்ல வந்து
அதுதான் நான் சொல்றேன், பிராக்டிஸும் இதெல்லாம் சம்பந்தமே கிடையாது. எக்ஸாம்ல உன்னை நீ காப்பாத்திக்கிறியா, அவ்வளவுதான். நீ சொன்ன பதிலுக்கு உன்னால ஜஸ்டிஃபை பண்ண முடியுதா? நீ சொல்லு, எஸ் ஐ வாண்ட் டு டேக் MRI. எக்ஸ்ரேல வந்து ஐ எம் ஃபைண்டிங் சம் லைட்டிக் ஏரியாஸ், சம் ஸ்க்ளீரோட்டிக் ஏரியாஸ் ஆர் seen. I am not sure whether it is going for an AVN. So I want to take an MRI and see whether it is an AVN. சரி, AVN இருந்தா என்ன பண்ணுவேன்னு கேட்பாங்க. 20 years தான் ஆகுது அந்த பேஷண்ட்டுக்கு. AVN இருந்தா என்ன பண்ணுவ? Now how will you answer? இப்ப நீ தான் கேண்டிடேட்னு வச்சுக்கோ, நான் கேட்கிறேன், நீ MRIன்னு சொல்லிட்ட, 20 years தான் ஆகுது, சரியா? MRI says there is an AVN. What you want to do?
Sir, if there is AVN, there is no role in a head preserving surgery, sir.
அப்படி கிடையாது சார். So I'm telling you, அப்படி கிடையாது. இது வந்து it is not like, hard and fast rule. இதுதான் அப்படின்னு அடிச்சுதான் சொல்ல முடியாது. நீ சொல்லி 20 years, that time you have to tell, sir, I will discuss with the patient. Okay? I will tell him, these are the complications. It's a AVN has occurred. Okay? But in spite of that, I can try achieve union. AVN ko union ko சம்பந்தம் இல்லை. ஓகேவா? AVN ஆன ஹெட்ல யூனியன் ஆகலாம்.
Okay, sir. Okay.
Okay?
Okay,
so
okay,
I will discuss with them and tell them. So there is a valgus osteotomy. If I do a valgus osteotomy, there is a chance of union, but still there is a chance of AVN. Ultimately, you might end up in a totally replacement, but maybe after a few years. Till that time, you might be able to manage. Or if the patient insists, no, I want only one surgery. I don't want any, because if THR பண்ணாலும் 15 years கழிச்சு என்ன பண்ணுவ? Again, you have to do a revision. திரும்பி 20 years கழிச்சு இன்னும் re-revision பண்ணணும். So these are all difficulties, okay, in doing THR. So exam na வந்து நீ சொல்லலாம், till you can say valgus osteotomy. It is only 20 years, sir, what to do? So if THR பண்ணாலும் அவனுக்கு திரும்பி இன்னொரு சர்ஜரி பண்ற மாதிரி ஆயிடும். So I might escape with the valgus osteotomy. இல்ல சார், 20 years அவனுக்கு வந்து AVN வந்துருச்சு சார், அவனால ஒண்ணுமே பண்ண முடியாது, அவன் டெஃபினட்டா வந்து ஒரு சார் எனக்கு வந்து லைஃப் வந்து ஆக்டிவா இருக்கணும், நான் வந்து ஆபரேஷன் பண்ணிட்டு திரும்பி வந்து I cannot be limping, அவன் ஆக்டிவா இருக்கணும்னு சொல்றான். So I will go for a total replacement. So it purely depends upon your common sense and your assessment of the examiner's pulse that you will answer this question. Okay?
Okay, sir. Okay, sir. Sir, another one question, sir. Sir, what is the golden period for the fixation of neck of femur, sir? Is there any specific time period, sir? Or
Prabha will answer.
Yes. You have to wait for 6 months because the fracture neck of femur has to unite now. You have to wait for minimum period of 6 months. Then only you can say it's a failed fixation, sir. That's given in the not like other things.
Okay, sir. Okay, sir. Okay, sir. Okay, sir.
Examல generally failed fixations usually வராதுப்பா, usually வராது. Okay, it will be a primary case. So ஒரு fixation பண்ணி fail ஆயிடுச்சு, usually அது வைக்க மாட்டாங்க எக்ஸாம்ல. அந்த மாதிரி இருந்துச்சுன்னா சர்ஜிக்கல் ஸ்கார் இருக்கும், சர்ஜரி பண்ணிருப்பாங்க, அதெல்லாம் நமக்கு தெரிஞ்சிடும். ஸோ யூஸ்வலா வந்து எக்ஸாம்ல வந்து சர்ஜிக்கல் பேஷன்ஸ் யூஸ்வலா வராது. பட் உங்க எக்ஸாமுக்கு கேஸ் வருமானே தெரியாது வரதராஜன். உங்க எக்ஸாமுக்கு வந்து கேஸ் வருமானே தெரியாது, அதனால நீ வந்து பெருசெல்லாம் கவலைப்பட வேண்டாம், சரியா? ஓகே, ஸோ we'll give you a scenario. You might, நீ கேட்ட அதே கேள்வி உனக்கு எக்ஸாம்ல வரலாம். நீ இப்ப பிரபாகர் சார் இதுக்கு முன்னாடி கேட்ட ஒரு கேள்வி, சார் MRI எடுக்கணுமா வேண்டாமான்ட்டு, இதே கேள்வி எக்ஸாம்ல வரலாம், இதே டவுட் உனக்கு எக்ஸாம்ல திரும்பி வரும். பட் நீ அப்ப வந்து கொஞ்சம் இன்டெலிஜென்ட்டா you have to answer and have to escape from the examiner. That's all. எக்ஸாம் பாஸ் பண்றது ஈஸிப்பா, நம்ம கொஞ்சம் அப்படி சாஃப்டா ரொம்ப தெரிஞ்ச மாதிரி காமிச்சிக்க வேண்டாம். பட் சேம் டைம் you have to tell the examiner that you know certain things very well. So எங்க வந்து எப்ப வந்து நிறுத்தி உனக்கு தெரியும்ன்றத நீ வந்து எஸ்டாப்ளிஷ் பண்றதும், உனக்கு எப்ப சார் இவ்வளவுலாம் எனக்கு தெரியாது சார் அப்படின்னு சொல்றதும் தான் examiner is a very safe approach. The examiner will be happy. ஒன்னு கண்டுக்கவே மாட்டார், நீ பாட்டுக்கு அப்படியே ஈஸியா வந்து you can move through. சப்போஸ் ரொம்ப ஸ்மார்ட்டா பிஹேவ் பண்ணாலோ இல்ல ஒண்ணுமே தெரியலனாலோ then only will be a problem. அது வராது, don't worry, அந்த அளவுக்கு வராது.
Okay, sir. Thank you, sir.
One doubt, sir.
Prabha, you want to add anything, any important point or something that you left behind?
So there was procedure called girdle stone arthroplasty, sir. Sometimes they will ask, sir, if whatever the fixation has failed at last you want a painless mobile hip, you delay the definitive procedure, that is replacement. Before that, what you do now, you have to resect the femoral head, infected femoral head and neck, whatever of a failed fixation head and neck, and leave it as such. That is called girdle stone arthroplasty.
Okay. And if arthrodesis is done, suppose arthrodesis is done, which is not being done at all,
Yes,
so
sir.
what will be the functional position at which the arthrodesis is done? This is for the sake of the postgraduate, because sometimes they might ask, again, they'll ask the arthrodesis, what is the functional position?
Yes, sir.
How much of abduction, how much of flexion and rotation?
Actually, abduction is around 45 degrees, sir. 40 degrees, sir. 40 degrees. 40 degrees, sir. 40 degrees, sir.
You mean it's arthrodesis?
Yes, sir. The Watson Jones approach.
40 degrees, no, not 40 degrees.
Okay, sir. Okay, sir.
Abduction is not 40 degrees. It is only 10-15 degrees of abduction, neutral rotation, okay, and in neutral flexion. Actually, up to 15 degrees of flexion you can allow. That is the function position. I think that is what is exam it be asked very frequently. It will be asked.
Okay, sir.
Or even 10 degree, even 5 degrees of external rotation of 10 degrees external rotation is also accepted. So better paathukonga, but these are the questions normally they will ask. Exacta book la irukadha padichu poidunga. So with that, I think
sir,
kele.
Sir, what is the difficulty in converting arthrodesis hip to THR, sir?
Arthrodesis hip to THR, okay. See, it's something like an ankylosed hip. Okay. So when they suppose in the approach la pova, which approach you follow, Kabilan?
Sir, posterior.
What approach do you do for total hip replacement?
Posterior approach, sir.
You do posterior approach. So posterior approach la incision eppadi poduva? Patient endha position la vechi incision poduva? First limb la.
Hello, sir. Kekling.
கேக்கலையா? ஹலோ
சார் சொல்லுங்க சார்.
இல்லப்பா, நீ போஸ்டர் அப்ரோச்ல ஹிப்ல இன்செஷன் வந்து போடணும்னா ஹிப் என்ன பொசிஷன்ல வச்சு போடுவ?
லேட்டரல் பொசிஷன் சார்.
லேட்டரல்டா, ஹிப் லிம்ப் என்ன பொசிஷன்ல வைப்ப? ஃப்ளெக்ஷன்ல வைப்பியா இல்ல எக்ஸ்டென்ஷன்ல வச்சு இன்செஷன் போடுவியா? ஹிப் அத சொன்ன பொசிஷன் ஃப்ளெக்ஷன்ல வச்சு தான் நம்ம இன்செஷன் போடுவோம். பொசிஷன் வந்து ஹிப் வந்து டிஸ்லோகேட் பண்ண முடியாது. இதுல ஃப்ளெக்ஷனே இல்ல எக்ஸ்டென்ஷன் எல்லாம் இருக்கும் உனக்கு arthrodesis. So from that time itself it is difficult. Even while exposing the hip you will have lot of difficulty. Okay, and the external rotators நம்ம rotate பண்ணுவோம். சரியா? external rotators பார்க்கணும், நல்லா internal rotate பண்ணாதான் external rotators start ஆகும். இல்லனா you will the sciatic nerve might get injured. Okay, so from positioning, from making the incision, dislocating the hip, everything will be difficult. You dislocate பண்ண முடியாது. You have to make an osteotomy in the neck and then dislocate. அப்ப ஹெட் வந்து ட்ரூ அஸ்டாபுலம் கண்டுபிடிக்க முடியாது.
Okay.
True acetabulum you cannot find out. நீ அதிகமா ரீம் பண்ணிடுவ இல்ல கம்மியா ரீம் பண்ணுவ. So many difficulties are there doing it, converting an still we can do. பண்ண முடியாது கிடையாது. ரெகுலரா பண்றவங்க it is not difficult. But there's so many difficulties, incision போடுறதுல இருந்து hip dislocate பண்றதுல true acetabulum கண்டுபிடிக்கிற வரைக்கும் it be difficult.
Okay.
So technically it is deadly. Otherwise there's no issue. If you're able to identify the true acetabulum, put the acetabular cup, then femoral side is going to be easy because you do osteotomy in the neck and then you dislocate. So these difficulties will be there in arthrodesis.
Okay.
So Kabilan, so bilateral arthrodesis, எந்த indication la பண்ணலாம்? When do you do a bilateral arthrodesis of hip? Kabilan.
We should not do bilateral arthrodesis for any patient.
அதான். So you never do a bilateral arthrodesis. Example வந்து bilateral arthrodesis பண்ணுவியா மாட்டியான்னு கேட்க மாட்டாங்க. இப்ப கேட்டேன் பாத்தியா? So which indication you will do bilateral arthrodesis? So they will confuse you. இப்ப நீ சொன்ன மாதிரி அடிச்சு சார் முடியவே முடியாது சார் பண்ணவே முடியாதுன்னா then it means that you are absolutely you know the answer. Okay, so no, never do bilateral arthrodesis. Okay. So anything more? I think we'll be close with this. Almost 1.5 hours ஆயிடுச்சு. So Prabha, even yeah, somebody wants to ask you, welcome. என்னப்பா புரியல?
Position of hip in arthrodesis, sir.
என்னமா சொல்லுமா? You want to say something?
No, sir.
இல்ல அதான். What is the ideal position for arthrodesis of hip? That's what you are asking, no?
Yes, sir. Yes, sir.
Yeah, ideally it has to be in 10 degrees of 10 to 15 degrees of abduction, neutral rotation, and 10 to 15 degrees of flexion. That will be the ideal position to orthodontic your hip. சில books la 5 ன்னு கொடுப்போம். 5 degrees of external rotation, 5 degrees of flexion, 5 degrees of abduction.
Okay, sir.
Chat box la I think there are a few more questions in chat box. பாத்துறலாம். Significance of Dassault sign in clinical examination. Oh my god, I'm seriously I don't know what is the Dassault
Dr.
sign.
Paramuraj, PG from Madurai Medical College, sir.
Thambi, really I don't know, I don't know this answer.
Sir, ஒண்ணுங்க சார், longitudinal rotation சார். அதாவது நம்ம நார்மலா ஃபீமர் வந்து நெக்கோட அட்டாச் ஆயிருக்கையில வந்து ஃபீமர் வந்து longitudinal rotate பண்ணையில நெக்கோட சேர்ந்து ரொட்டேட் ஆகாதுங்க சார். சப்போஸ் நெக்காத ஃபீமர் ஃபிராக்சர் இருக்கையில it will rotate around the long axis on its own சார். அது வந்து ஒரு கிளினிக்கல் சைன் சார். அது ஒரு சில புக்ஸ்ல கொடுத்துருக்கு, வர்ஷன்ல கொடுத்துருக்குங்க சார். அது இந்த சைன் வர்ஷன்ல சார். அது சில டைம் கேட்பாங்க. அத பத்தி தெரிஞ்சுக்கணும்.
இல்ல seriously இல்ல one thing, sorry I didn't get your name. பேர் என்னமா?
Paramaguru Rajesh from Madurai Medical.
Paramaguru Rajesh. Yeah, okay. See, one thing I will tell you, is, I have not heard of the Dassault sign. Okay, sorry, I seriously have never heard of any people asking the sign at all. And one more thing is, never
femoral graft is technically high demanding and needs a meticulous care, sir. It's a long time, needs a long period. So nowadays
sila institution la பண்றாங்க. Because Madurai Medical College la they will be doing definitely vascular, because they have a good team of microvascular team, so definitely they will be doing. KMC லையும் one case they are doing, MMC they are doing.
I mobilized 2 cases.
So if exam la சொல்லலாம், if you are doing it in your institution you can say, or if you are confident about that